Hello, this is Jehan Budak from the University of Washington, and this National HIV Curriculum mini-lecture will report back from the ID Week 2022 conference. We will focus on two topics. First, the preliminary results from the BEe-HIVe study regarding hepatitis B vaccine efficacy in persons with HIV when using HBcAb, which I will heretofore refer to as the HBcPG vaccine, and real-world outcomes with injectable cabotegravir-rilpivirine. First, let us discuss the preliminary results from BEe-HIVe. As a reminder, hepatitis B vaccine seroprotection rates, or SPR, in persons with HIV are lower, ranging from 18 to 71%, than in adults without HIV, in whom we may see SPRs ranging from 60 to 80%. The HBcPG vaccine, FDA approved in 2017, is a 2-dose series for adults greater than or equal to 18 years old. In immunocompetent adults, SPRs with Hep B vaccine, the Endrix or Recombavax types, range from 65 to 80% versus 90 to 95% with Hep B CPG vaccine. But how efficacious is Hep B CPG in persons with HIV? In a single-center study of 51 persons with HIV without immunity to hepatitis B receiving the Hep B CPG vaccine, SPRs were overall 82%, with high SPR in those with higher CD4 counts. And ultimately, to answer this question, we have been awaiting data from BEe-HIVe. The B-Enhancement of Hep B Vaccination in persons with HIV, or BEe-HIVe study, included persons with HIV aged 18 to 70 on ART with a viral load less than 1,000 copies per milliliter, CD4 greater than 100, negative hepatitis B surface antibody, no prior history of hepatitis B, and who were not pregnant. Today we will focus on results from Arm B. However, to bring everyone up to date on what Arm A is, that was a study arm in vaccine non-responders, where they are comparing 2 and 3 doses of Hep B CPG versus 3 doses of the prior recombinant vaccine, NGB. At ID Week, we received preliminary data from the results of Arm B, which was administration of 3 doses of Hep B CPG. This is different than we traditionally see, as typically the Hep B CPG vaccine is a 2-dose series. Study objectives were as follows. 1. To determine SPR, defined as Hep B surface antibody greater than or equal to 10, at 28 weeks after 3-dose Hep B CPG in Hep B vaccine-naive persons with HIV. And to describe grade 3 or greater adverse events. A visual representation of the timeline of vaccination is shown here. Hep B CPG was given at entry, 4 weeks, and 24 weeks, and individuals were followed out to 72 weeks. Most of us are used to administering Hep B CPG vaccine at entry and at 4 weeks, as previously mentioned, instead of a 3-dose vaccine series, and luckily serologic data were obtained at several points throughout the study from which we can extrapolate. With regard to patient characteristics, of the 74 individuals in Arm B, the median age was 47. 46% were male at birth, 54% female at birth. 96% had a viral load less than 60, and the median CD4 count was 625, and the median nadir CD4 count was 247. The graph on this slide shows the SPRs by study week. On the x-axis are time points in weeks, and the y-axis is percentage of patients with a Hep B surface antibody greater than 10. As a reminder, vaccine was given at entry, week 4, and week 24. You can see that quite shortly after the second dose, SPR rates were high, and that by week 24, prior even to receiving the third dose, 98.5% of individuals had a surface antibody greater than 10. This next graph is similar to the one above, and instead of showing you only those with surface antibody greater than 10, differentiates between those with surface antibody greater than 1,000 and greater than 10. A takeaway is that this is an immunogenic vaccine. It was a well-tolerated vaccine. 61% of individuals experienced greater than or equal to 1 adverse effect related to study treatment, 39% of whom had a grade 1 AE, and 20% of whom had a grade 2 AE. What were those adverse effects? 40% of individuals had an injection site reaction, and then approximately 20 participants each experienced malaise, fatigue, myalgia, and headache. So in summary, BEe-HIVE aims to evaluate the safety and immunogenicity of Hep B CpG vaccine in adults with HIV. We received results from Arm B at ID week, in which 68 Hep B vaccine naive persons with HIV received 3 doses of Hep B CpG, and 100% achieved SPR. There were no unexpected safety issues or deaths, but limitations of the study include low representation from predictors of non-response, such as low CD4 cell count, viremia, or hepatitis C, and that it only addresses the 3-dose series and not the 2-dose Hep B CpG protocol most of us use in clinical practice. Despite this, we can gather from the serologic data obtained that 98.5% of participants achieved SPR at week 24 after just 2 doses. Thus, this is a highly immunogenic and safe vaccine for persons with HIV who are vaccine naive, and we are still awaiting efficacy data in vaccine non-responders, which is the Arm A of the protocol. Next, we will share outcomes or results from oral abstracts regarding long-acting injectable cabotegravir-rilpivirine. And specifically, we will review use of long-acting injectable CAB-RIL in the OPERA cohort, low-level HBViremia in core antibody-positive, surface antigen-negative persons with HIV switched to long-acting injectable cabotegravir-rilpivirine, and share about implementation experience from EU clinical sites. First, real-world use and effectiveness of long-acting injectable cabotegravir-rilpivirine in the OPERA cohort. As a reminder, the OPERA cohort is a cohort of 145,000, approximately, persons with HIV in 96 clinics in the United States. Among this cohort, between January 2021 and February 2022, 383 individuals received their first dose of cabotegravir-rilpivirine. Of these individuals, the majority had a viral load less than 50, and only 7% had a viral load greater than 200. 2% had no baseline viral load. At the end of the study period, 89% remained on therapy. Of those with a viral load less than 200 prior to initiation of long-acting injectable cabotegravir-rilpivirine, 99% maintained viral load less than 200 at the end of follow-up. And of those virally unsuppressed at initiation, 91% achieved a viral load less than 200 at the end of follow-up. The next study was a retrospective case series of 149 persons with HIV switched to long-acting injectable cabotegravir-rilpivirine at a clinic at UC San Diego. Of the 149 patients on long-acting injectable cabotegravir-rilpivirine at their clinic, approximately 25% were Hep B core antibody positive and surface antigen negative. Of those, 8% developed low-level Hep B viremia, which ranged anywhere from less than 10 to 101 IUs per milliliter. When did these individuals become Hep B viremic? 2 at the time of their first long-acting injectable cabotegravir-rilpivirine dose after the oral lead-in, and the other between the first and second doses. One of these individuals had Hep B surface antibody positivity prior to switch, but the other did not. In response to these changes, 2 switched to BIC/TAF FTC and achieved Hep B viral suppression, and 1 continued long-acting injectable cabotegravir-rilpivirine, and the Hep B DNA level decreased from 14 to less than 10. Ultimately, the clinical significance of this very low-level hepatitis B viremia is unknown. Last, the CARISEL study was a VEe-sponsored Phase 3b multi-center open-label implementation effectiveness trial examining strategies to support implementation of long-acting injectable cabotegravir-rilpivirine across 5 EU countries. It included 437 participants at 18 clinical sites with 70 staff providers. It compared implementation using a standard arm versus an enhanced arm. Whereas the standard arm included educational resources and virtual injection training, the enhanced arm included face-to-face injection training, continuous quality improvement, and educational resources. Regardless of the intensity of the arm, at 12 months, viral suppression was 87% across both arms. In conclusion, notable abstracts from ID Week 2022 showed us that Hep B CpG vaccine is safe and effective in Hep B vaccine-naive persons with HIV. Though the 2-dose protocol was not used, we can extrapolate that vaccine is efficacious after only 2 doses, and we are still awaiting results from the vaccine non-responders. With regards to long-acting injectable cabotegravir-rilpivirine, virologic outcomes early after persons with HIV in the OPERA cohort switched to cabotegravir-rilpivirine demonstrated high rates of viral suppression and low rates of virologic failure. Of another cohort of 149 persons with HIV switched to long-acting injectable cabotegravir-rilpivirine, 38 were Hep B core antibody positive surface antigen negative, and 3 of those individuals developed Hep B low-level viremia, the clinical significance of which is unknown. And last, regardless of implementation support and clinical infrastructure across 18 clinical sites in the EU, long-acting injectable cabotegravir-rilpivirine was effective. Thank you.
The production of this National HIV Curriculum Mini-Lecture was supported by funding from the Health Resources and Services Administration.